What we're going to do in the next sort of about 45 minutes or so is cover four main areas. A brief skim overview of the DVLA rules, bit about how to do Forrest plots, duties of a doctor, and then sensitivity and specificity all sort of condensed down. Just a reminder for those who've just joined, this will be recorded. As I said, all of your names, I'm not going to answer questions throughout, but please, please, please chuck them in the Q&A and I'll pick them up at the end. I'm not going to mention your names because I want to put this presentation out on YouTube and it's really not fair on you guys. So why the heck am I doing this, Dave? So this is an extract from an e-learning package that I put through together. I'm a GP trainer and I have been now for the past 3 years now. I've just got have my first trainee from start to finish. She's due to CCT in February. She's from Nigeria originally, and between her and I've had one who was from Syria originally, who both were clinically phenomenal, but really struggled with the stats and the admin element of the AKT, as per a lot of the registrars in the area. So I put together the other 20% AKT course, which the web address is down below there, and I've given you a discount code towards the end as well. It's now coming up to, this will be the sort of the fourth exam that people have used the AKT course. What's really brilliant is that, just to be mindful of, in October of this year, the AKT changed, okay, in terms of the timings and also the number of questions, which is good and bad. It means that you're in the exam period for fewer minutes of time, but it does mean that if you really struggle with your stats and the admin, look at this, like you're only getting 16 stats-based questions and 15 organization management questions, which means that there is greater, you have to be really confident on this area to boost this up. This was a chap that actually worked with my wife, who's an A&E consultant, and was doing his A&E rotation and sort of said, like, Dave, could you help me out? He got onto the course and he's done phenomenally well. Okay. And we're getting about that sort of the 60 to 80% in terms of the pass mark, which is marvelous for me. Keeps me warm and fuzzy. So let's rattle through DVLA rules. Okay. If you haven't got this document already, do not revise from anything else. Go onto the DVLA and type in Assessing Fitness to Drive, a guide for medical professionals, and download the PDF. Okay, if you're in your training or in your practice and you've got dual screens, I used to have this fixed on my as one of my regular bits that I would have a look at, because you always go back to it. Okay. The patients think it's a very simple question of, can I drive, doc? And it's not. It's not a simple yes or no, and there are multiple shades of grey. Driving falls into occupational health, which is a speciality in its own right. And just remember that the DVLA has its own group of doctors, okay? And it's down to them to make those tricky and difficult decisions. All that you have to do as the GP is provide information. You are not categorizing whether they are safe to drive, okay? And if it's not written down in this guide, don't say anything or defer it to the DVLA. Okay. So just bear in mind that there are two types of driving license that you can get in the grand scheme of things: Group 1 and a Group 2. Group 1 is if you're a driver, that's pretty much what you've got. Okay. It's related to a car or a motorcycle, and you'll 10 yearly auto renew until you're 70 and then 3 yearly after a medical review. Group 2 is for your large good vehicles or your passenger carrying vehicles, okay? So think basically if it can lose control or have an issue, how much damage is it going to cause? So lorries are often like a couple of tons at the very least, so are going to cause a heck of a lot of damage if someone comes out of control. And a cab, even though you might think, well, it's just a car, but you're carrying passengers, okay? And so you're putting other people at risk. Occupational health is this mixture. I love a bit of occupational health. It's basically the real life application of it. So it's how then basically you as the individual, your medical conditions may affect your workplace, and then likewise how your workplace may affect your medical condition. You'll probably see a couple of army bits in the background. Occupational health in the military is huge because you're putting people into difficult and dangerous situations. So are you giving them the right equipment? Okay, so on that way, and actually what sort of issues are then going on to affect them in the workplace. Okay, so think about how to apply this to a car, and you can sort of suss out, if you go through system by system, what they need to do, and so where the errors may occur. So if you're thinking about what the brain needs to do, it needs to process information, make difficult decisions, Your eyes, they need to see the road both day and night, okay, and also perceive and see hazards. Your heart needs to keep the rest of your organs perfused. So, is it making your brain perfused? Okay, and likewise, your blood sugars need to be maintained stable, and then your arms and legs need to control the vehicle. Okay, so it's very simplistic, but actually, that should give you a couple of handrails to think, well, actually, if they've broken their arm, are they fit to drive? Probably not. So let's go through some key points. So first, unprovoked or suspected epileptic seizure. Okay, group one, driving must cease for 6 months from the date of seizure. Okay, or for 12 months if there is an underlying causative factor that may increase risk. What you'll often find, you think, well, hang on a second, how the heck am I meant to know if it's going to increase risk or not? Well, actually, that's where neurology and your local specialists really come in. And often, what the DVLA will do is pull that information from them to make that assessment. Okay. And that's why it says must not drive and must inform the DVLA. And that time frame is there to really sort of help you out. Group two, so your lorry drivers, think about them must cease 5 years from the date of the last seizure. Okay, and it'll talk about percentage of there's a 2% charge of further seizure. I wouldn't expect you to remember that, but it's one of those of again referring back to your specialities. If you've got epilepsy or multiple unprovoked seizures, so we're talking single, so your first fit compared to multiple now, where group one is very much a must not drive from the date of recent seizure for 12 months, okay? And then group two, the person with epilepsy must remain seizure free for 10 years without medication before licensing can be considered. So this is huge, so you just bear that in mind in terms of who is having that impact, who's having, if you're saying that someone's got a seizure, it's going to be a very delicate conversation that you must have to make sure that they're safe from that way. So, stroke and venous thrombosis, driving may resume after 1 month if there has been satisfactory clinical recovery, and DVLA does not need to be notified. Okay, so if there's any residual neurological deficit 1 month after, they need to comment on whether their visual fields are correct. So, can they see generally their peripherals, cognitive deficit, and any impaired limb function? Must not drive, and they may need to inform the DVLA. Again, neurology normally do that. I've been on the receiving end of the DVLA forms, and they will often ask about eyesight, limb function, etc., etc. Okay, and then group two is that they'll be refused for 1 year following a stroke or a TIA, and they must be informed. So you can see the discrepancy between the two, deliberately so. After a heart attack, so ACS, so if you've got a normal PCI, you may sort of drive after 1 week, and you must have, a left ventricular fraction greater than 40% before hospital discharge, i.e., have they had an echo? Okay, if it's not treated, so you've had a rise in troponin, they're doing medical management, you've got to have at least a month from the acute event. Okay, and they may not need to inform the DVLA. Okay, so group two, this is your lorry drivers, license will be refused or revoked. Okay. And it may be after 6 weeks if the requirements for exercise or other functional tests can be met and the LV ejection fraction is at least 40%. Again, that functional testing is not the role of the GP, often either occupational health triggered by the driving company that they work for, or from the DVLA themselves will be able to sort of manage, can they do that from that way? So don't get drawn into this. And again, LV ejection fractions, have they had an echo? Is it satisfactory? Okay, so insulin treated diabetes, all the following criteria must be met, and there must be an adequate awareness of hypoglycemia, no more than one episode of severe hypoglycemia, and they practice appropriate glucose monitoring. And it's not regarded as a likely risk to the public whilst driving, i.e., are they going all over the place, and they meet the visual standards for acuity and visual fields, and they're under regular review, and they must notify the DVLA. Okay. Again, similar rules for group two, okay, making sure that if you're insulin treated diabetes, that everything is, well under control and you're fully aware. What's interesting is that they've just updated this. Apologies, the slide isn't updated. That continuous glucose monitoring is acceptable now, which is great. Even just to prove, just so don't be surprised if they mention that in the DVLA rules when you go and investigate this. So think about eyesight standards. Okay, so basically it's can you read a number plate? That's all they're asking about. really. So when you see all these weird sort of figures, so at a distance of 20 meters with letters and numbers measuring 79 millimeters high and 50 millimeters wide on a car registered since the 1st of September 2001. So when they changed the number plates, I'm old enough to remember when they did that. Okay. Or at a distance of 20.5 meters with letters and numbers 79 millimeters high by 57 millimeters wide on a car registered before 1st of September 2001. Okay. Um, Visual acuity, a Snellen chart of 6/12 with both eyes open or in the only eye if monocular, and horizontal field, so that way of 120 degrees. Okay, so can you see the peripheral arcs? What I would say about this is one of those that they're, however you remember these weird and wonderful facts, sort of make sure that you sort of push them in and get them sort of down, because it's a really good one. So group two, so again, your lorry drivers, that your Snellen chart is at least 6/7.5 and 6/60 in the poorer eye. Okay, and again, if glasses are worn, the corrective power is no more than 8 + 8 diopters. Again, we're not expecting you to assess that. Okay, that's where you sort of like, you need to get the optician report. And your Snellen chart 6/12 in both eyes open or in the only eye if monocular. Okay, so that is DVLA rules in a very, very brief nutshell. Make sure that you go and read that if you haven't, or pick out those things. It's a big document, okay? It's about 100 odd pages long because it covers everything. But what I want you to do is pick out the common things. So as I've done there, ACS, stroke, first fit, what would you do with alcoholics as well would be worthwhile. But again, just be cautious about diving too deep into it, okay? So we're going to go on to a bit of stats at the moment. Okay, feel free to chuck any questions in the Q&A and I'll pick them up at the end. Okay, and we're going to talk through Forrest plots. An amazing, amazing question to ask. So Forrest plot. What we're going to do is, if you're looking at a question like this and you're panicking, okay, thinking, oh, I hope they don't shove that in the AKT, then we're going to talk through this and we'll make you experts by the end of this. Okay, so you're reviewing a latest article around the effectiveness of physical activity promotion based in primary care, and we're reviewing the following Forrest plots. What conclusions can be drawn from the diagram? Select one or more answers. Okay, so you've got all of these A to H and basically saying which is right, which is wrong. And you think, hang on a second, where the heck would I start with this? So let's go through this in detail. Okay, so first thing you need to do is look right at the bottom. Okay, so you've got this as the main sort of output for any of these RCTs, where you've got, again, favors control and favors intervention. Now, depending on what the study is, that might slightly alter, okay? But you should, regardless, have this solid line. And that line is called the line of no effect, okay? So if anything touches that, then it's not statistically significant. Your next bit is you've got this black diamond. That represents the overall, like, average results from the study itself, okay? And you can see here that the top of the diamond stands for your mean change, okay? So where has it gone? And then you've got your upper and lower confidence intervals by the point of the diamond. Now, already, if the upper or lower confidence interval does not touch that line of no effect, okay, then you know it's significant. As soon as it touches it, regardless of what the result is, it is not statistically significant. Okay. Then what we're doing is we start to add these studies, and you see they've got a box, okay, and then these lines. The lines represent the upper and lower confidence interval, and then the box represents the power of the study. Okay. Now, for any statistical purists in the audience, I apologize, I'm going to butcher this, but in short, it's how many people are in the study. Okay, it's actually how many how the study is powered, and there is a correlation between sample size and power. But there is, just for the sake of, if you're struggling with this, just remember the bigger the box, the larger the number of people, and you're not going to go too far wrong. So again, you've got here the line representing the lower and the upper confidence interval. And as you can see here, we start to add more studies and we apply the same thing. Okay, so With these studies here, you can see that they do not touch the line of no effect, okay? And they are on the favors intervention. So we can start to build up two things. So we can say they favor intervention, and because they're clear of that solid line, that they are statistically significant. So because they are clear of the line and they're over in the favors intervention, they favor intervention and statistically significant. Okay, you can say, well, hang on a second, Dave, what about these? Okay, they still clearly favor intervention because, they mainly over onto that side, but they're touching the line. Well, exactly that. They still favor intervention, but it's not statistically significant. Okay, so you've got those two things that you're going to have a look at, and you can start to mentally go through them. Okay, and so you can see out of all of these three studies favor intervention and are statistically significant. Bear that in mind. All of these, then, you can see are touching the line, so aren't statistically significant, and the majority of them do not touch, or sorry, are on the favors intervention side, and there's one that's sort of on the favors control side. Okay, and this one you're like, well, for the sake of argument, it's just over on that side. So let's go through this. Okay, so no conclusion can be drawn. Well, sounds a bit false, okay, because we've just done one. All of the studies favor control. Nope. All of the studies favor intervention. No. Okay, overall, the conclusion favors intervention. Well, we've talked about that. That's the diamond. So, yes, 3 of the studies favor intervention and are statistically significant. Yes. 5 of the studies favor intervention. Well, what I've done is I've marked that wrong. Okay, that was me writing this question. It's meant to say and are statistically significant. 1 of the studies favor control but is not statistically significant. Again, that's that top one, so that's true. Okay, Lawton 2008 is the highest powered study. So if you have a look at this, you're thinking, hang on a second, which one has got the biggest box? Well, you can see that's a nice chunky one there, and Lawton 2008. Boom. You could also, to double check, but this may not be on the actual exam, look at the weight, and you can see that the percentage of it, 16.7%. Quick glance up and down, actually, that's the highest number. So that is correct as well. Okay, so that's Forrest plots in a very big nutshell. Okay. So we're going to rattle on through to duties of a doctor, and it's worthwhile being aware we're going to talk over the broad aspects of duty of the doctor, but we're then going to push this forward into 3 areas, okay? We're going to really focus on the duties of a doctor, what it says, and then also appraisal and revalidation. Due to time, I haven't got the GMC and social media, but actually we'll try and reflect upon those as well. GMC have got specific guidance on how doctors and healthcare, or those registered with the GMC, should present themselves on social media, and it's worth a read. In about a year or 2 ago, it cropped up onto the AKT about specific questions, but we'll try and reflect onto it. It boils down to just be nice and reflect the GMC rules, okay? So duties of a doctor covers 4 broad areas, okay? Knowledge, skills and performance, safety and quality, communication, partnership and teamwork, and maintaining trust. Okay, so for your appraisal, so just to run it through, the majority of you, I'm assuming, are ST2, okay? Or, so you've done your exams, you've CCT'd, congratulations. And then what do you do next? How do the GMC and the UK sort of make sure that you are safe to still practice as a doctor? So effectively, I want to tell you that you get rid of your portfolio. Unfortunately not. I do apologise. You still have to maintain a portfolio and very similar to what you're doing at the moment. The benefit is it's nowhere near as hard work as your current portfolio that you have to do for training. Okay, so once you're qualified, or if you say take a career break or whatever, you still have to maintain an appraisal. So as I said, I'm ex-army. I was technically for a period of time out of training because I was in the military as a junior doctor, and I had to do an appraisal on a yearly basis because I was post-foundation. I wasn't in my GP training. I had to do it from that way. Okay. So revalidation occurs every 5 years from registering with the GMC. So if you're new to the UK, that will start from when you've fully registered with it. Okay, so if you are UK graduate and you've done your F1, F2, and then your ST1, 2, 3 is GP training, that's your 5 years. The benefit if you're doing it that way is that there's very little for you to do because what the GMC does, it goes, right, you were in training for an F1, you were in training for an F2, and you've been in training for ST1, 2, 3, and it's automatically done. Okay, there is a bit more work, like for me, when I had to be revalidated to make sure that my appraisals are all up to date. Okay. Big things. Your supporting information, continuous professional development. So if you go on a course and or do an hour's worth of work, that's technically classed as one CPD. You'll see that some courses will be recommended as CPD accredited. Marvelous. Okay, I just went on a day course that was 6 hours worth of CPD. Trick question, and depending on where you used to go, it used to be that you had to do 50 hours of CPD a year as a minimum. Okay, that has gone, like completely gone. That was removed as of during COVID and the sort of the pandemic, basically to try and minimize the work that GPs had to do. All you had to do is just prove that you are being, that you are maintaining your skills and accuracy. I would argue that 50 hours is still very achievable and actually not very hard to do. As long the hard bit is actually recording it all down, okay, and actually sort of like reflecting on what you've just seen, what you've read, etc., etc. Okay, but for an exam question, how many hours do you have to do once you're fully qualified? The answer is 0. Okay. If you look at an older question bank, they may mark that as wrong and put it as 50, and you can tell you're on an old question bank because that's what it used to be. Okay. You still have to do quality improvement activities. You still have to reflect on significant events and serious incidents. And every 5 years, you have to get feedback from patients that you provide medical services to. That's once every 5 years, not like you lovely people that have to do it what seems to be at least every year, if not more. And also the same for colleague feedback and any reflect again any compliments and complaints. Your appraisal itself is very similar to your portfolio. So 14 Fish do offer a professional portfolio, which I use because it's easy. And that will take your personal information, appraisal information, your scope of work, and that's very important, okay, and your previous appraisals, and also a PDP that you well know, and also looks more wider at your challenges, achievements, aspirations, as well as your personal and professional well-being. Okay, now just be mindful of, because the scope of nature of your work reflects against the GMC, so you need to be very careful in terms of how you project your work, okay, and what areas you work in, that you are maintaining your professional credibility in those areas. For example, I'm a GP trainer, so I need to make sure that whatever I'm doing, I'm maintaining my quality and maintaining my education in being an educator from that way. I'm also a GP, so I need to make sure that I am, making sure that I'm up to date with certain criteria and that I'm giving the appropriate information to patients, etc., etc. Again, knowledge, skills, and performance. Make the care of your patient your first concern and provide a good standard of practice and care to keep your professional knowledge and skills up to date, and recognize and work within the limits of your competence. And this is key. So, for example, I am not minor surgery trained. So if I went out to do a minor surgery course, then that's fine. But actually, what I would expect to do is then I need to sort of maintain that skills and profession. Okay. And I need to reflect that in my portfolio, for example. Again, so just keep it very clear in your mind about sectioning each work and prove that you're maintaining this area, and you can allocate certain CPD to that area. So, for example, I had one bit that I wasn't putting much work into, and as part of my PDP, I need to put some more into it this year, which is fine and easy enough to do. Okay, so safety and quality. Take proper action if you think the patient safety, dignity, or comfort has been compromised, and protect and promote the health of patients and the public. Now, this is an interesting GMC point because it then reflects nicely into social media. And where some doctors have come a cropper is that they think that Human Rights Act states that you've got freedom of information and freedom of speech, okay, which you think, brilliant, okay. But when you're becoming a doctor and when you're registered as a doctor, if your thoughts and opinions could potentially bring harm to the public, then you as a professional, your professional standards out trumps your human rights. Okay, so let me just sort of say that again. Your professional standards, as outlined by the GMC, trumps your human rights. Okay, so if you went on to X, LinkedIn, whatever, and said you shouldn't be having COVID-19 vaccinations, or you shouldn't be having your flu vaccinations because they're going to cause you harm, then actually, because of how you present yourself online as a doctor, you could put yourself at risk from the GMC for potentially putting patients at harm by encouraging them not to get vaccinated as an example. Okay, so if you're going to put health advice out, just be very, very, very careful. And that's why it's sort of like I'm not saying not to do it, because I'd be a massive hypocrite if I told you not to, but just be very careful and making sure that it aligns with whatever college you're part of. So for our example, it would be the RCGP. Okay, so treat patients as individuals with dignity and respect their dignity. Treat patients politely and considerately and respect patients' right to confidentiality. Okay, so again, social media really kicks in with this one, making sure that you do not post, or I've just seen this patient today, that they could themselves identify, as that will get you into hot water. I've even seen, I'll be very careful, I'm part of multiple Facebook groups, which are full of GPs, and it's brilliant for sharing information, getting knowledge. I am very mindful not to post patient information onto there because it's not safe, okay, for multiple reasons. And I just wouldn't do it. I would sort of seek help either in-house or through your secure routes, okay? Because if a patient found it, then they could legitimately complain against you, and you really haven't got a legs to stand on. So, working with partners and patients, listen to and respond to their concerns and preferences, give patients the information they want to in a way that they need to understand, and respect patients' right to reach decisions with you about their treatment and care, and support patients in caring for themselves and improving and maintaining their health. Okay. So again, this really falls back into your appraisal, with where you need to reflect on any compliments or complaints on a yearly basis, even if it's a nice thank you card. Patient feedback questionnaire at least every 5 years, and that's patients and colleagues. Just remember that's both. Okay, maintaining trust. Be open and trustworthy, and always acting with integrity. Never discriminate unfairly against patients or colleagues. Okay, this again falls into social media really nicely, and the reason why I came off X and not really active anymore, though I will admit I do have an active account, I just don't monitor it, because of the big pile-on to physician associates. Now, regardless of your opinion on physician associates and whether they're safe or unsafe in a primary care setting, the way that people treated them and commented about them on X predominantly is where I saw it, was pretty disgusting. And actually, I'm curious, and I'd be curious to see if anyone actually fall foul of it. In my opinion, they fell foul of the social media policy that the GMC put out, because they were discriminating against colleagues, okay, by saying they're all this, that, and the other, okay? So never abuse your patient's trust in you or the public's trust in the profession, and you are personally accountable for your professional practice. Must always be prepared to justify your decisions and actions. Fair enough. Okay, so last bit now, not all doom and gloom. Okay, so what we're going to do is, just to sort of round things up, we're going to touch about sensitivity and specificity. So what I want you to think about is, when you're dealing with sensitivity and specificity, people are like, oh, what does that actually mean? What you're actually dealing with is a simple test and a complex test. Now, the benefit for you, lovely people, is that the simple test you've got in general practice, okay? And it's basically, does your simple test correlate with the likelihood of it diagnosing a particular condition? Okay. Now, your complex test could be anything up to an autopsy that shows that they've got a particular type of cancer, or just dial it back a bit into something a bit more realistic, like prostate cancer. You've got your simple test of your rectal exam and your PSA, and you've got your complex test of your MRI pelvis, which is generally what's done now. Okay, to the point where you think, for the complex test, is the consultant or whoever's in charge of that particular area happy that that pretty much diagnoses that condition? Okay, so you've got your screening criteria, or your sort of like your initial investigations, your simple ones, and then your more complex ones. Okay, so for example, breast cancer being classic one. Examination, you found a lump in your breast. What is the likelihood versus your, I put mammogram here, I would argue probably, like your ultrasound, your fine needle biopsies, etc., etc., your complex test that way. How do the two correlate? Okay, so from finding a lump there to diagnosing breast cancer through whatever means. PE, classic one. How many D dimer, positive D dimer versus a CTPA, which confirms or denies that they've got a massive clot in their lungs. Okay, pneumonia, point of care CRP or POC, as you've seen there, versus your chest X-ray and full blood count, which shows the raised white cell count. And I've already mentioned about the PSA versus MRI pelvis. Now, when you're looking at the two, you'll see, in terms of these often common findings of like your true positives, your true negatives, your false positives, false negatives, and you're like, what does that mean? Okay. What I want you to do is to think of it backwards. Okay, so for example, the last bit, the positive or negative, means that has it tripped over, has that initial test, so the simple test, is that down to, is that positive or negative? Okay, so is that result of significance? So if you've got a raised PSA of say 10 or something like that, or 20, that's sort of like a high number. Okay, so has it tripped over that line to think I need to do it about it? What then the true and the false means is that have you done all those initial of subsequent investigations? So, for example, going back to prostate cancer, have you done those investigations and they've come back either representing that they've got cancer? So, for example, a true positive will be that you've got a patient that comes in, they've got a PSA of 20, you send them on the 2 week wait, MRI confirms that they've got prostate cancer. That means that that result there was a true positive. Okay, it was over the limit, so it's positive, and they've had all the investigations prove that they got cancer. It was true. Okay. Likewise, true negative. So, for example, you're in a testing phase and you do a PSA, it's negative. For whatever reason, they've had an MRI of pelvis. And again, that proves that they don't have prostate cancer. Okay. So, you've got a negative result, so a low PSA, and that they've gone through all of the test investigation, and that is negative as well. Think about a lot of your screenings that, for example, you do, mammograms. Okay. And, a lady self examines, no lumps found. She goes for a routine mammogram, which shows that there's no signs of cancer there. So a true negative. Okay. So false positive. These are the ones we get concerned about. PSA is the classic one. How many raised PSAs have you seen? I've seen loads in my time that you then go to do the investigations and the MRI comes back as just a benign prostatic hypertrophy and they say chuck them on tamsulosin and do it. So that you've got a raised PSA, that means the positive, so it's enough that you've triggered a 2 week wait, you've gone through all of the test investigation and it's found nothing to be there. Okay. And then a false negative. So these are your tricky ones, your incidental findings that effectively they've had a negative result. Okay. So a normal result, whatever it may be, they've gone through for whatever reason, there'll be an incidental finding, or they've just so it's happened where at the end of it, they found to have that condition. Okay. Not a nice place to be in. So from the data, you can actually work out 5 things, but due to time, we're only going to focus on 2 of them, that's sensitivity and specificity. What you need to do is to sort of chuck it all into a table. Okay, so down on the left hand side, that is your initial test. Okay, so the test that you've done, say in primary care, is your test positive or is it test negative? And then I've put here disease present, disease absent, but again, that's just sort of like what you're doing here, and you can soon work out. It's like, right, well, if I've got a positive test and the disease is present, that's a true positive. Lovely. And if I've got a test that's negative and the disease is absent, that's a true negative. Marvelous. Okay, but if the test is positive, they've gone through all of the investigations and the disease is absent, that's a false positive, and likewise false negative as well. Okay, so make sure that you're mindful and wary of that. So your sensitivity then is how good at the test is predicting people with the condition. Okay, so you're looking at that true positive and you're wanting that percentage over the whole sort of column. So how many false negatives, how many people is it missing out that particular investigation? Then your specificity is again, how good is it at ruling people out of the condition? Okay, which is marvelous. So this is taken from the Liverpool trial when sort of during the height of the COVID-19, where they did the lateral flow test. So what everyone was getting, through the post versus a PCR. Okay, so the ones where you had to send them to the labs. With this trial, what they did is that they basically had 2 tents, and you go 3,000 people went through there and thereabouts. And you went, right, you go into tent 1, get your lateral flow done, tent 2, get your PCR done, off you go. Okay, so sensitivity is here, and you can see out of this column, so 22, so your true positives divided by the total in that column there. Okay, 22 divided by 45, which equals 0.49. Okay, which overall is 49%. Okay, so that's the sensitivity of it. Your specificity then is this column. Okay, so you've got 2,979, so it's your true negative. So they've had a lateral flow that's negative and a PCR that agrees with it. Okay, and show that actually it's a very specific investigation. Okay, and you're getting out at 99%. Fine, right. Phew. Glad it happened there. Perfect timing, really, because that is pretty much the end of it. Um, what I was just going to say, chuck any questions in. I hope you found that useful. If you're interested in doing the course, docsupport.co.uk, RCGP AKT course, from that wine, this gives you an overview of what the course entails. Okay, so you've got basically a couple of introduction modules, 10 top tips for the AKT, and you've got 10 statistics modules, which mean, median, mode, confidence intervals, part one and two, sensitivity and specificity, which goes into the full 5 areas, screening, outline of evidence-based medicine, and then goes through each of them. And then there's one how to answer any AKT stats question, which goes into a breakdown of what to look at. The admin side looks at your sick note rules, your DVLA rules, aviation rules, patient practice interaction, which means goes all the way through from registration, notes access, and then what to do after they die, bit about GP contracts, and then duties of a doctor from that way. If you're interested, there are multiple, you can either access it for a week, a month, or 50 days. There is a 48-hour one as well. And because I'm being nice, if you type in DocS15 as a thank you for coming along today, you get 15% off all packages with it as well. Okay. Your 50-day access, if you are really struggling with this area, the 50-day access, if you sign up today, should take you pretty much to the exam itself. Okay, so that is that from there. That QR code will take you to it. So what I will do is, if you've got any questions, please shove it in now. I apologize again for the slight hiccup, but it seemed to work out. And just, yeah, throw away. I'm going to be, my clinic doesn't start for a while. So please, if you've got any questions about the AKT, about revision, please just chuck them in. This won't be part of the recording. If, if not, I'll let you go. But yeah, just please chuck them in.